Hi, I'm Stephanie Shelton, and this is Conversations on Health, How We Get There, episode 25. Health experts in many countries, including the United States, are looking beyond standard health care and medical treatments to some kind of community-based care, both as a way to improve people's general health and as a way to cut the spiraling costs of medical procedures and new drugs. The Netherlands appears to be well ahead of most countries with its varied efforts to reinvent what is generally called social care, starting right at the neighborhood level. With the huge boomer population aging so quickly, the Netherlands also has a particular focus on what it calls integrated care. That's for people with multiple health issues, which includes giving them access to adequate health care before those issues become serious and expensive to treat. My guest is one of the Netherlands' top experts in this area, Professor Dr. Mirella M.N. Minkman of Tilburg University, TS Business School, and CEO of Vilans, National Center of Expertise for Care and Support. We cover a lot of territory, including what is a growing problem virtually everywhere, more and more young people with mental health needs. You'll be surprised to find out how varied and sometimes how simple social care really is. Mirella, thank you so much for taking the time to come on the podcast.
Yeah, it's a pleasure, Stephanie. So thanks for inviting me. It's a pleasure.
So, we know very little about the Netherlands health system, and it always amazes me that every country in Europe has something that is similar to each other, but different. So where, just give us an overview of how it works. And I know it has to do with a combination of public and private, which sounds very complicated to me.
So it's indeed what you say is a kind of a combination between private and public. But on the basic, you could say that also how it's financed, it's partly by taxes, the government, you could say, all incomes. And it's also partly by the people themselves. But from that part, it's merely also by employers, you could say. So people work and they get a salary, of course, but from that salary, a part of the premium is also sent by the employers to a national and one national amount of money, you could say, that's being used. And on the other side, people also do have own contributions, but that's if you look at the total part, that's rather limited. But it is own contribution and sometimes some direct payments.
So do you call it, do you think of it as universal health care? Is everybody covered some way?
Well, more or less, yes, I would say, and that's because it's accessible in principle for all people in the Netherlands, and all people do have to have insurance. So you have to have an insurance and healthcare insurance,
And that's private?
well, partly you could say because you have to pay apart from your netto salary to directly to a healthcare insurer, and you choose your own healthcare insurer, of course. But of course, that doesn't cover all the costs. So also apart from the employers go to the national fund, you could say, and also from taxes, money has to come into that fund, and the total funds are being divided, you could say, to the healthcare providers who provide care and get paid for their services. But I think the good thing is that, and that's I think is a difference between our system and that's in your country, is that the idea is that we want to be there for everybody in the country. So you have to have an insurance, and everybody has an insurance, except for people who might be just arrived in the Netherlands or are illegal, or so that's luckily a small amount of people. So the majority of people who are just living and working and being in the Netherlands do have an insurance and go first if there's something the matter, you could say, what they cannot solve themselves, to the general practitioner. And the general practitioner well, as the first person to contact and to see what's necessary.
That sounds somewhat similar, except for the money aspect of it, to the UK system, where the GP
Yeah,
is first
yeah,
and then
yeah.
referrals.
We also have a kind of a gatekeeper system, you could say. For most people, we luckily do have a general practitioner, but there are now coming situations where there's really a shortage, so then we have an issue. But the system itself has the idea that you first go to what we say services nearby your home, nearby where you live, and that's your general practitioner and other services, and that a person sees what's necessary, and also tries to reduce, of course, unnecessary visits to specialty care.
It sounds in many ways kind of like what our system might evolve into,
Mhm,
because it is this combination of public and private.
mhm.
And as more and more people age in this country, more and more people are in the public part of it,
Yes,
but
yeah.
we've already paid into it with taxes, and we
Mhm,
pay even more for it, as we use it. It's like an insurance in a sense.
mhm.
Um, but it is this combination, and we're always talking about this split in our country.
Yeah.
But and the more I listen to this, the more I think, well, we're not that far off.
Okay, okay. Well, that would be possible. And of course, that's not our total system, you could say,
Right.
because we want to strengthen. I think it's very important to strengthen also a care very nearby where people live. That's very important, first line, or preventing that it's really care, you could say. And then we run into you could say, the social care domain, or just having support in your daily living. And then, of course, we have different acts, you could say, which define also what kind of services are being paid for or not. So we have a health insurance act, you could say, but we have also an act for youth care, and we have a long-term care act, for instance. We have a totally integrated system, and you can imagine that, of course, if you look through the eyes of people and the lives of people, that they go through the system, you could say, and the system is not always adaptable enough where people are. So we
Well,
try to improve that, of course.
all right.
Yeah.
So let's kind of move into the social care area, which is your specialty, and which I particularly am interested in because to me that's a term that takes in that neighborhood care where
Mhm,
things
mhm,
start in your neighborhood, and where people who are not necessarily associated with annual medical checks and going to doctors can still get some kind of outreach.
mhm.
Um, it seems that might not be an issue in your country because I think I read somewhere that 95% of the Dutch are connected to a general practitioner. Is that
Mhm.
true or?
Yeah, I think that that's true. That's true. That's related to what we just talked about. That you have to be have an insurance and be subscribed at a general practitioner in your neighborhood. So that's for most of the people the issue, but still, that's not, in my definition, you could say real, or well, real social care, because what we see in the Netherlands, also because the changing demographics, and that's also issues where we as Vilans are working on very hard, is also to be much more earlier, you could say, in how can we change, and not really as a healthcare system, but more as a society. How can we, you can say, strengthen or neighborhoods, communities, that they are alert and cooperative in well, working together, I would say living together, people in a certain area, a certain community, or a certain neighborhood, that they can help each other with all kind of, well, often more social or social issues, like supporting each other with little tasks, or getting some groceries, or helping driving you to the doctor if it's possible, is it needed, etc. And also preventing loneliness and things like that. And we see a very interesting development in the Netherlands, that because of the changing demographics, and because we already have and will have a more shortage in professionals in the system, you could say, so nurses and home carers, etc., that more and more the public, or just the Dutch citizen, you could say, is being aware that they also have a role themselves. And what we now see is that it's on the rise, that in a lot of neighborhoods, there are initiatives, and they call themselves with all different names, but well, let's say caring communities or caring neighborhoods, where they start initiatives in where they can support each other, and take all kind of initiatives to do it with each other, um, to prevent also that people with more social needs, you could say, end up at the GP.
All right,
Yeah.
so let's kind of move into the social care area, which is your specialty and which I particularly am interested in because to me that's a term that takes in that neighborhood care where
Mhm,
things
mhm,
start in your neighborhood, and where people who are not necessarily associated with annual medical checks and going to doctors can still get some kind of outreach.
mhm,
Um, it seems that might not be an issue in your country because I think I read somewhere that 95% of the Dutch are connected to a general practitioner. Is that
mhm.
true or?
Yeah, I think that that's true. That's true. That's related to what we just talked about. That you have to be have an insurance and be subscribed at a general practitioner in your neighborhood. So that's for most of the people the issue, but still, that's not, in my definition, you could say real, or well, real social care, because what we see in the Netherlands, also because the changing demographics, and that's also issues where we as Vilans are working on very hard, is also to be much more earlier, you could say, in how can we change, and not really as a healthcare system, but more as a society. How can we, you can say, strengthen or neighborhoods, communities, that they are alert and cooperative in well, working together, I would say living together, people in a certain area and certain community or certain neighborhood, that they can help each other with all kind of, well, often more social or social issues, like supporting each other with little tasks, or getting some groceries, or helping driving you to the doctor if it's possible, is it needed, etc. And also preventing loneliness and things like that. And we see a very interesting development in the Netherlands, that because of the changing demographics, and because we already have and will have a more shortage in professionals in the system, you could say, so nurses and home carers, etc., that more and more the public, or just the Dutch citizen, you could say, is being aware that they also have a role themselves. And what we now see is that it's on the rise, that in a lot of neighborhoods, there are initiatives, and they call themselves with all different names, but well, let's say caring communities or caring neighborhoods, where they start initiatives in where they can support each other, and take all kind of initiatives to do it with each other, um, to prevent also that people with more social needs, you could say, end up at the GP.
I think maybe we're all beginning to look at things this way. I mean, there's a lot of talk about this in the United States, but it's really difficult because we have deep pockets of poverty and
Mm.
low
Yeah.
education levels and distrust
Mhm.
among many people for the medical profession or for healthcare workers or for
Mhm.
people they don't know,
Yeah.
from their church or something like that. But there is this beginning, I think of a person as a whole person.
Mhm.
It's not that, oh, I've got mental issues. Oh, I've got a broken arm. Oh, I don't feel so good in my stomach today. It's like maybe that stomach is related to your mental issues, to your feelings about yourself and society, and and
Exactly.
on and on
Yeah.
and on.
Yes.
Um, and that seems to me a really good thing, but maybe because of the size of your country, you can contemplate it. But here in the United States, with, you know, 8 million people in New York City, for example, and
Mhm.
and then the surrounding tight suburbs where everybody lives in their own house,
Mhm.
how do you manage to get this not just the idea across, but get it working?
Yeah. Yeah, that's a very interesting question. And I'm not sure if size of the country is the crucial factor to get it working or not, because I think it really also starting with another mindset, because when we saw it happening in the Netherlands, and as Vilans, we were very interested and first wanted to monitor also this development. So what's happening, and is it just some pilot projects or whatever, or is it really on the move? And now we see that's really more than 2,000 of these kind of initiatives, national programs who support it, etc. And first, we also thought, well, maybe if it's in the community or the little villages and things like that, there might it work, and maybe not in the big cities. But that's not the issue. That's what we learned. So it's not. You can also have, and of course, the scale is small. So if you have a big city, then the city is not the scale to work on. It should be very local. So it starts with having, I think, a different mindset. First, of knowing your neighbors, who's living nearby, who's willing to support. Do you know each other? Do you trust each other? I think these kind of issues are very important. And of course, there have to be some people who take the initiative, take the lead, etc. You have to know your community, and sometimes we have examples that it helps if you have someone who's a very, you kind of say, a connecting person who is a kind
Yeah,
of
yeah.
a spider in the web, and knows all those people, and knows that Stephanie, that you're very willing to walk my dog, but I can't because I'm not that good with working and walking anymore. But and she knows that you can help me with my dog, but I can help you with something else.
This,
So
it's very much, I'm listening to you talk and I'm thinking, because we talk a lot about, and in our country, it's a political divide.
mhm,
The Republicans expect things to be like they used to be, where the church and the neighborhood organizations and family and friends took care of each other, because we were all so much smaller too, and lived in smaller towns. And the Democrats expect the government to do it.
mhm.
And and
Yes.
and neither of them are working very well anymore. But what you're talking about is, in a sense, a return to what was when we did used to know each other. If you live in a small town, even today, you know everybody. Everybody knows you. And a lot of that just happened. I notice when we go to this into areas in the South where the church is important,
Mhm,
that
mhm,
the church is the center. The church takes care of people. They know if
mhm.
somebody's sick, and somebody from the church will go with hot food, and it
Yeah.
it isn't even organized. It just happens.
Yeah, yeah, yeah. Well, it has indeed similarities with that, and it's also, and maybe we don't have the Democrats and the Republicans, but we also have people, of course, and that's historically based, where people expect that the government or will take care of you and will pay everything and things
Yeah.
like that. So that's also, and also a lot of people, of course, who worked whole their lives and are now old and ill and think, yeah, I worked all my life, I paid all my life, so now I'm in need, so and now I have to do it myself. What's this? But I think it's partly it's a minority, but so still, of course, you expect to be supported. And I think in essence that's the case, because we try to well, of course, spend money well and have effective treatments and have support for everybody who is in need of support. I'm very also I think that's very important. It's a kind of a civilization of your society, I would say. Yeah. So if you are able to support everybody who's really in need, but on the other hand, there's also an own responsibility. There's an own responsibility, well, to live as healthy as possible. There's you have a responsibility, of course, to take care of your children. That's normal. That's what we accept, you could say. But well, it's more and more people are aware that okay, well, if we have a shortages of people who are working as nurses and things like that, and you won't have automatically the nurse at home 3 times a day because well, she most of them it's still she's not there, it's not available anymore.
Mm.
So what are we going to do? Are we just going to complain, or are we going to do it ourselves? So I think that's a kind of a mind shift. And of course, people are not all of them are thinking the same. So there's still people who expect that it's being arranged, or maybe are not that aware about all the changes in healthcare settings because, well, they live in other sectors, and well, if the problem is there, then you start thinking about it. Huh? But on the other hand, there's also a very large group of, you could say, relatively healthy and younger elderly who do realize, okay, it's not that automatically more that there there's total support for me and care. And what's also very important is that a lot of people, and we did some research, of course, also knowing the needs of elderly people, what do they want? They want to live at home. They want to live in a home environment. So if you ask it if you ask the people, only very small percentages says, well, just you could say, bring me to a nursing home. And that's not because the nursing homes are that bad in our country. I think they're very caring and loving staff, and they're trying to improve and have a good environment and things like that in our elderly care. But it's just a basic need that people like, well, their own environment, their own, well, and also having people that they know, trust, and can support nearby, and also some facilities.
And then it's somewhat the same here. The same group of relatively healthy older people who do not who want to stay in their home,
Yeah.
and more than that, who don't have the money to do anything else. Almost nobody does,
Mm.
because then the long-term living, the assisted living facilities, as we call them, most of that's private and costs an arm and a leg. And
Mm.
it's very hard. You'll go through your entire savings in a year or two. And the ones that are supported by what we call Medicaid, which is the health program for the um, poorer people, people who fall under a certain salary line, and they're very spare and unattractive. And of course, all facilities, hospitals, nursing homes, it doesn't matter, are short-staffed now. Nobody has enough
Yeah,
staff.
exactly.
And that seems to be country to country. I mean,
Yeah, yeah, yeah.
Um,
That's interesting. Yeah.
so
So
let me just ask you, before we go back into that area, um, there was something I read about that you're doing, which is called integrated care for
Mhm.
people with chronic conditions. And that I had not heard of before. Can you talk a little bit more about that?
Well, yes, that all started years and years ago, because I think if you look at, well, you could say my expertise is also about the innovation of the organization of care and support. So, well, how should it look like? And it's very important that that starts from the total perspective of on a person, on the needs of a person. And the integrated care field, which is, well, it's not a new area, you could say, but it's a kind of way of working and thinking
Mm.
that when you start from the person's perspective and there is something the matter with the person, that you look at what is the matter, but also what's related to that and what will support this person. And sometimes that's something different than just curing it, because if somebody has diabetes and is obese or something, then most of the time that's not just a medical treatment. It's
Mm.
how is someone living, how is someone cooking, what is the issue. So my vision is, if you don't start with looking from a more integrated perspective on the issues of people, then you just are optimizing, because you're just fixing one part of the issue. And integrated care is, you could say, the way of thinking, but it's a way of organizing, that you start with what are the total needs, what's the issue, and then organize it in such a way that it contributes to the needs of that person or a group of person or of person with a special need. Yeah.
That sounds very practical. And it also sounds like it doesn't cost a lot of money. Like it actually the other way around, it might save a lot of money.
Yes, indeed, and indeed that would be the issue, but the complexity is, of course, that the systems, and that's not something just from the Netherlands, but we see it internationally, because the International Foundation for Integrated Care is working all over the world, that all kind of systems are designed in, you could say, in silos most of the
Yes.
time, which do not cover the needs of people, but are, well, you could say professional based or disease based or a specific service based. And that's very, I can imagine that it's being designed like that. But if you would design it again, then of course you might have designed it in another way. So it seems simple, but in fact, it's very complex to come to such a situation, because we are in a specific situation where the organization, the way that people are educated, the financing systems are not from an integrated perspective often. So sometimes there are, of course, initiatives and policy measures that do stimulate it in this integrated approach. In the Netherlands, we have, for instance, the Integrated Care Act. So that's not law, it's an act. It's a kind of a statement, you could say, of all kind of parties who are involved in healthcare settings, that we wanted to work towards more well integrated approaches. So that's a good thing.
And it's also this integration of social care and medical care. What I like to just call healthcare,
Mhm,
as a
mhm,
huge general term. In the United States, I don't know if you know, but um, physicians, hospitals, they're paid per procedure.
mhm,
I mean,
mhm.
it's not even disease related.
Yeah,
And they're trying to change some of that in hospitals so that you get paid for the complete outcomes. I mean, it's such a mess, at
yeah.
least here.
Yeah, I can imagine. And well, I wouldn't say it's such a mess maybe in our country, but we still also have uh, paid by performance or production, I would say. So we also still have that. So uh, on the one hand, we're thinking about what is, we call it in the Netherlands, suitable care. So
Mm.
what's appropriate to do and what's not. And it's also very important that the professionals themselves also, well, be critical, you could say, and reflective about what is necessary to do and what not. Do you really have to ask that patients to come back in 3 to 6 months or whatever? So that's a kind of a call that's also towards professionals. But at the same time, we still have that healthcare insurance and healthcare providers do make agreements about production. So it's about volume, you could say. So and of course, we see in every system that people behave accordingly what's being rewarded. So if you get paid more, if you do more, well, the chance is very high that people will do more.
Yeah,
So
yeah.
I think these kind of incentives are not pointing into the right direction. So that's very important that people are, you could say, efficient. Of course, do as much as they can do in the time they have, or the money or the means they have, but are not being, you could say, seduced to do more because it's being paid more. Because then, of course, cost will rise. That's, yeah,
Uh,
unpredictable, I think.
Let me go back to the social care concept. Um, one of the things that I'm reading about in some of the papers that are being written here now on our social care is the movement of people from a hospital into, say, a rehabilitation center or directly into their home if they have somebody to take care of them, that there's no coordination between what has been done for them in the hospital, say physical therapy, and the
Mm.
information that the other place gets, or the visiting nurse that comes to visit you in your home. And so for a nursing home, for example, the person who's been moved there may be insisting on walking without any help. I won't use a walker. I won't use a cane. I don't want you to help me. I want to walk. But that information has not been given to
Mm.
the nursing home.
Oh, yeah,
And then there are accidents. That person falls because they can't really walk on their own and they're not being aided in the right way. And then it just, somebody
yeah,
breaks a hip who didn't have to break a hip.
oh, yeah,
And that's also an issue that we're
yeah,
talking about here.
yeah, yeah. I can imagine that that's you want to prevent any time, of course. Well, that's about, you could say, information, transformation of information and
Exactly.
knowledge also, and continuity of care, that are the concepts you were talking about with this practical example, I think. And that's of course very, very important. And what we see in the Netherlands, I think that if someone goes from the hospital towards a nursing home, there is a transfer of information. Um, but what we see is that our ICT health systems are not all totally connected,
Mhm.
because they have different ICT systems, of course. So it's not that fast as you would want it to have. But and we don't have one national system, you could say, where all healthcare providers are into. But well, there is a transfer of information from one provider or professional to the other. I think that's, but still, there are a lot of improvements made also in that, what can be made still in that area. But I think it's even more, it's coordination and being proactive. I think
Mhm.
that's even more important, besides, of course, having the right information on the right time. That's, of course, information. So what we now see also, that's interesting, that well, if people go home again after a procedure, whatever, then of
Mhm.
course the general practitioner again is in the lead, you could say, and maybe some home care assistants or people, friends, relatives, whatever, who can support. Um, so that's important. But now we see first experiments also in hospitals, that because of short of staff in hospitals, but also while being prepared for the future, pilots were also informal carers, you could say, and family do tasks in the hospital
Uh-huh.
for patients. And also we have the first initiatives about, you could say, informal carers academies by hospitals, so that family members are being trained to do specific things at home and to learn how to care for your loved one. So
Wow, what a great idea.
yeah, yeah, yeah. I mean, now see the first experiments, and well, it's also being evaluated, and I don't have seen and read all the research about it yet. But it's interesting that from the
Yeah.
media, I would say that the first evaluations seem to be a positive. That patients, you would say, like it to be helped by a loved one, you could say, or someone who's caring for you. And it's also, of course, it's a different role also for nurses and for people who are trained to support, to help, to train to support, and of course are willing to help. But it's more thinking about, it's another perspective again about how can we use people, means, and what we do have. So maybe we don't have to look at what we don't have, but what do we have, and how can we use it in an appropriate way, which might be different than a traditional way.
Yep. It sounds really promising. The other thing that sounds really promising, and I was reading it on the Vilans website, was this story or article that you wrote about re-enablement
Mhm.
and this concept that there are all kinds of little things that you can do to enable a person, and then often it's an elderly person, to have more confidence in their ability to do things themselves.
Yeah.
And they're not always what you might think.
Mhm.
Some of them were really tiny.
Yeah, they are really practical daily living things, you could say. And also, again, it's also giving people knowledge, support, or tools, maybe, or digital tools to do things themselves, or to be in the lead for themselves. So that's all about, and learning how to do that, and not taking over, because, well, of course, as a human, you sometimes just want to help, and I'll help you, and I'll do that for you. So, and well, so it's also a good thing that people learn to do things themselves, also things that they maybe were not used to do so. For instance, if you have a couple, an elderly couple, and one of the two dies, then you had a certain role division between those two people, and then the one who's left has to learn maybe new things which were in the package, you could say, of the deceased person.
Yeah.
So it's not that that person don't is not able to do so, but maybe is not used to do so, or doesn't haven't done it before, and things like that. So you can bring somebody a meal, but you can also learn someone to cook. So that's the difference.
It's a term that sounds re-enablement, maybe a little bit wonky, if you know that word, for just average people. But the concept and the concept that if you were, say, a team of nurses who do home care,
Mm.
that as you said, you have to kind of hold yourself back. And what was the example that I found interesting, that if it was a regular caregiver, they had a key to the house
Mhm.
and they would just let themselves in and say, hello, Sam, I'm here. Um, and instead of that, you would ring the doorbell and expect the person, even if it's only a tiny little short walk, and even if they're using a walker, to walk to the door and let you in. And that's more like what you do with a friend,
Mhm.
who went over for a visit or something.
Yeah, exactly.
I just found that fascinating.
Yeah, it's also kind of a normalization, you could say. So it's out of your healthcare role, and it's about, okay, I'm going to visit Stephanie today. And what do I do if I visit you? Of course, I ring the doorbell. And maybe you need some extra minutes, but if I know you were able to walk to the door, so I just wait a little bit longer.
How does that go over with trained personnel?
Well, I think it's on the one hand it's challenging, of course, because it's also a change for staff who's trained now till now in another way, and also sometimes can feel a little bit contradictory, because if you ask people who are working in healthcare professions, they have chosen that role often because they like supporting people. And they've learned that and are trained by that. So it's different than they are trained for. But on the other hand, people understand and know, and also do support the aims that you want. If you want people to be as long in their own lead, you could say, or leading their own lives as possible, that's a supportive way, but it's ask another rules. Well, most of the time you just have to do it and experience what it does, and then you are convinced. Yeah.
And that's very much what you were saying earlier, that people have to take some responsibility. This is now the individual who's being helped have to take some responsibility for their own care, their own health,
Yeah.
instead
Yeah.
of just sitting back and saying, well, it's hard for me to walk over there and get a glass of water. Would you get it for me? No, you
Mhm.
can actually do it yourself and you'll
Yeah.
feel better about
Yeah.
it. But
Yeah.
that's a mindset.
It's a mindset, and it's not because, and that's also for the professionals important to explain, of course, that it's not there, that's not the issue that they don't want to, or they don't want to support you, or they want to get a glass of water. And they try to support you. That's also, if I'm not there, that you can take the second glass of water or the third or whatever.
Yeah, yeah.
So that's another mindset. Yeah.
So putting all of this together, um, what my mind goes, because I'm also a business reporter, is all of these little things that are either re-enabling people to help themselves or thinking as a totality about healthcare, and in thinking in the neighborhoods in terms of prevention. Can you quantify in any way yet if that is beginning to save large amounts of money?
That's a very difficult question to answer, because I think that this is a development that we see, and of course maybe we also have a little bias because we are so busy with it, you could say, and we are interested in it and doing projects with it, etc. So to really point out how large this movement is, and also as a researcher and as a scientist, I'm very curious also what's, you could say, the maximum and what's also not possible, because it might seem as a perfect solution, but of course it's not, because there are also disadvantages, and so we have to learn in the future. So we also have to be very aware. What are the side effects? When doesn't it work? We don't want to have that informal carers are too stressed out, or well, so there are also other possibly negative effects. Although we now see it as a kind of a positive and a developing movement, but then translating it in cost savings. That's your question.
Yeah.
I think it's very hard to point out figures, because we have a number of issues at the same time. We have the rise of demographics, of course, of both in the Netherlands, we have more people, so we are a growing population, but also within that, we have, of course, an increase in elderly people who are, you could say, the most costly at the latest, the last years of their lives. Um, but well, I think by giving more incentives in France and towards communities, and having support that people can meet each other, can support each other, that there is a coordination of these kind of services. Um, I think that could save money. That could save a lot of money. Yeah, and people will still get sick and will have cancer and need treatment and things like that. Of course, we cannot prevent that, but I think every euro in our country which will be put in front of these kind of support, well, will deliver savings later on. But it's difficult because when you save, but at the same time, a number of people are on the rise. So the more people with
Yeah.
multimorbidities, costs, of course, of treatments are sometimes very expensive medication and things like that. So there are multiple factors that influence the amount of money, you could say. But I think you could say penny wise, pound foolish if you don't support this movement. So
What are you doing about the migrant crisis? I mean, we talk about people coming in who might
mhm,
need everything because they come with nothing, and
mhm.
and they just are there.
From a health perspective, of
Yeah.
course, that's yeah, that's of course it's also an important issue. And well, what are we doing about it? Of course, all people who are entering our country, you could say, we try to support them and give them the basics. But well, of course, all those people do have, and I think, of course, tremendous experiences and mental needs maybe because they all experience sometimes horrible things, and
Yeah.
so I think the mental health aspect is even more important there, and that's also an area we didn't discuss yet in our talk. That's in my perspective, also without just looking at the issue of migrants and new people, is an important aspect if I look at the mental health care and youth, for instance. That's what we see in our country. That it's puzzling. That's puzzling me also that you see that a lot of younger people who, well, that it's quite a challenging time frame, I think, for younger people. And then I mean, for instance, about well, let's say 18 plus till 30 or something. So in that developing moment in your life, you could say that is a lot of youth who are struggling with all the kind of pressures, you could say, who are there in society and how to handle with that. So there's also you see at different at universities and things like that. That's an issue. How do we deal with that? And how do we see that all the young people, you could say, also have a good, well, you could not only a physical health, but also a mental health and can cope with the challenges of life. That's really an issue also, I think.
A friend of ours that I have interviewed for this podcast, he's a psychologist, a clinical
Mhm.
psychologist, and we've gotten to be friends. So I interviewed him. And his comment about young people was, and he was talking about Czechs, was that they're not being raised to be resilient anymore.
Mhm.
That the first thing that is difficult to deal with that hits them knocks them over mentally. They
Mm.
literally don't know how to get back up and face whatever they have to face and move forward.
Yeah, it could be. It's not my field of expertise, but that's what we see also in the Netherlands. And just yesterday, a colleague of mine told something about his daughter, and he said, "Well, I now start just saying it to people because I didn't do it earlier. That my daughter is not feeling well, and we're having troubles with her." And he also said, "Well, every when I tell it to someone, everybody says, 'Oh, I know also someone, and my neighbor, and well, whatever.'" So, and maybe it's also about adaptivity. It's also coping, you could say. Yeah, maybe it's not that difficult, like we discussed with being in the elderly phase of life. So supporting you that you can live your life. And
Mhm.
then we talked about little things you could say. Yeah, so getting the glass of water. But in the earlier years of your life, well, you have also challenges, sometimes bigger challenges. So how do you learn to cope? So maybe that's a kind of an area how, as humans, as people, do we are we supported, but also do we support each other more on that social connection, so that you help me and I help you a little bit, and maybe together we fix it.
All right, let's kind of wrap this up with again looking at the future, unless there's something else you want to talk about first. Um,
That's okay.
um, of course, my idea of the future is combined helping people be healthier people, complete healthy people, and also how are we ever going to find the money to spend on the people who do need it? Because everything from a medical standpoint is so incredibly expensive now, the new drugs, the new procedures, everything.
Mm.
Um, so it always comes back to this integrated social care with health care
Yes.
to a point of are we going to be able to save enough money on the one side so that we are going to be able to afford the other side?
Yes, I think that's and my inaugural speech was also called for longing for integration or for integrated services. I think that that's more or less the solution is there because we have to start looking at what do we have, so and what will we have in the future in persons, in money, but also in needs, you could say, and how we're going to match that in the best way. So, and it starts at the front, you could say, in supporting people to live their own lives, you could say, on their own, together with all, of course, relatives and neighborhoods, things like that. as long as possible and live their lives as healthy as possible. And of course, that will not solve everything. So, and then have a kind of a good, smooth system where people can have support as close as possible in their home, possibly hybrid care, but also with digital solutions, which are on the rise, that can be also in the home environment be supported. And when that's not enough, then of course, and you need a treatment or things like that, you have to see someone who is specialized in that. And it's also the question, where do you have to see that person? And of course, when it's a procedure, you have to have a facility where a safe procedure can be executed, of course.
Right.
But it's kind of a way of organizing these kind of services from that perspective. And then, of course, doing treatment and care support that is efficient and that's really is necessary with the money we have, and then have people as soon as possible, if they're not in their home situation, back in the home situation where they're not alone and being left alone, but where they are being cared for in a way that's necessary and that's supportive for their total recovery, or their palliative care and their end of life care.
It does seem to me, listening to you, and you mentioned it earlier, that the people who do this structural thinking for all industries, and all industries have these structural problems that they're dealing with, the movement toward the future, had better sit down and start talking to each other and doing this structural restructuring, taking into consideration the digital advances, AI, which should help in some ways, and just people themselves. You kind of need the planners up here, and you need some real people, as we say in the journalism profession, to come in down here and talk to each other.
Yes, I think that's important, and we don't have to wait for the next big transformation or system reform or whatever, because we know from worldwide that there is not a perfect system, and there are differences, of course, and advantages and disadvantages. But it's also, you can do very much within the system what's already there, and of course, systems are important to support and to have the right incentives that people act in the right behavior. Also professionals, also just people. But I think there's no time to wait for, because if we see what's coming up, the shortage of staff, the possibilities also on the positive side of digital hybrid care, the number of people who are have multi-mobilities, elderly people, but on the other side, positive also the willingness of people to do something, to act. So I think we should just grab that together and make it work as good as possible.
Okay, well, I think this is as good a place to leave it as any, unless there's something else you want to add to that.
I think for this moment we can talk on and on about this topic, I think, but for this moment, I think this will do. Yeah.
Well, thank you, Mirella. I really appreciate your knowledge and your thinking, and for coming on the podcast. It was really good.
Thank you. It was a pleasure. Thank you for inviting me, Stephanie.
I hope you discovered as much as I did from my guest, Professor Dr. Mirella M.N. Minkman of Tilburg University, TS Business School, and CEO of Vilans, National Center of Expertise for Care and Support in the Netherlands. I'll link to the Vilans webpage in the show notes. Now, back to the U.S. Every year in mid-fall, Americans get a chance to re-up or change their secondary Medicare insurance companies, or choose an all-in-one Medicare Advantage plan. In 2025, thanks to the Biden-Harris administration's Inflation Reduction Act, there will be a number of consumer-friendly changes, including a new $2,000 yearly spending cap on out-of-pocket drug spending in the Part D drug coverage plan. And some very expensive drugs may already be a little bit cheaper after Medicare for the first time was allowed to negotiate lower prices, which start in 2026, for the 10 drugs which cost Medicare the most. In our next podcast, episodes 26 and 27, we'll review the Medicare changes and standard procedures for signing up, and also review Obamacare, or as it's officially known, the Affordable Care Act, which also has a fall window to sign on or make changes in existing coverage. I schedule one new podcast episode a month, so look for this next episode in October. The drop day is usually the third Tuesday of the month. Updates on my show notes podcast page, and I would really appreciate it if you'd subscribe and, of course, share. We're on Apple, YouTube Music, Spotify, TuneIn, Amazon Music, iHeart, Podchaser, and my host platform, the Podbeam app. The video version is on YouTube. Show notes and links on my website, www.stephanieshelton.com/conversations. If you like the podcast, please leave a review or give us a rating wherever you listen or watch. I'm Stephanie Shelton, and until I see you again, please take care of yourself and all those you love. Conversations on Health, How We Get There is produced and edited by Frank Harold. Research assistance from Dr. Richard Saltman, Professor Emeritus of Health Policy and Management, Rollins School of Public Health at Emory University in Atlanta.